Hello, everybody. We opened up the room just a minute early. We're going to get started here in just a minute. I want to thank you for joining us for this special webinar on the first Thursday in January, where we can talk about the No Surprises Act with Dr. Munsterman. Just going to give everybody another minute to come in. Hi, Rach. I'm looking to see who else here. And Michael and well, I am so happy, Angela, that you were happy to find this webinar. It's so funny. Dr. Munsterman was super nice in making time in his schedule for us to be able to do this. When I just called him, I was like, so about that No Surprises Act. We probably should have a webinar about that, but everybody was shutting down for the holidays. So we were like, let's do it on a Thursday. And he made time in his schedule. So we're super appreciative. All right. It is noon my time, 1:11 or 10 your time, depending on where you are. And if you're in Alaska and Hawaii or Guam, I'm not even going to try to figure that part out because we are broadcasting in all of those areas and sometimes overseas. So welcome and happy Thursday. Thank you so much for being here. Dr. Scott Munsterman is a presenter that is, no stranger to anyone. He's a frequent guest on our webinar series because honestly, it's all about quality. And if you're going to have somebody come in here and talk to you guys about compliance or regulation changes, or because, some government acronym decided to put out a 6,000 page document about something, he's really the guy I want to tell y'all all about it and how it applies to you, because he's the person who actually reads all 6,000 pages. I'm not saying that this was 6,000. I'm sure it was a lot, but that's what he does. And he dives deep and then he breaks it down in a way so that you guys understand exactly what about this new rule or regulation, how it applies to your chiropractic office, how to easily implement that so that you can remain compliant and focus on what is most important, and that is taking care of your patients. So Dr. Munsterman, thank you for being here. Thank you for always making time in your schedule to do these things.
Oh, well, you're very welcome. And I'm always honored. And you know that. So, well, yeah, welcome everybody. And what's a better way to start out the new year than knowing that we need to comply to something new, right? And so I'm going to shut my video feed off. So we've got good bandwidth all the way around. And to kind of get things kicked off here, the No Surprises Act actually, as we think about the where it began and where it came from, was developed back in December of 2020, and it became part of a law that addresses primarily surprise billings. And as we get into this in more detail, just like we always do share with you, we don't want you just to take our word for it, but we definitely want to provide you with where to find the source, that primary source verification. And so these are the primary links that you can click on to read more about it. CMS has got a pretty good overall rule, fact sheet that you can read from. And then to Christy's point, if you want to dive right into the law, when it was passed in December, they actually wrote the rules that were published then into the Federal Register. One came out around in June, and then the other one came out, part 2 came out in October. And so we're going to speak to this in the way that it was laid out, part 1 and part 2, so that you can very concisely give it some clarity that we need to have around it. And then at the end of the day, we'll boil it right down very quickly to what is it that we as chiropractic clinicians need to be the most focused on. And that'll become quite evident and quite clear. And at the end of the day, it tells us that we need to provide what are called good faith estimates. And we're going to talk about that. And the whole premise behind the law is to eliminate surprise billing. Well, what's a surprise bill? Well, that's an unexpected balance bill that a patient could get from a provider or a healthcare facility. And so the scenario kind of goes like this. Scott goes to the emergency room. He's got an urgent emergency condition. He gets seen at that hospital or urgent care center. And then a month later gets a bill for $30,000 and that I need to pay. Right. And I'm like, well, how come my insurance didn't cover this? Well, I wasn't told that the provider that saw me wasn't a participating provider, or I didn't know that maybe the provider I saw was participating provider, but maybe the person who put me under for anesthesia or, so-and-so or whatever wasn't. And so all of a sudden I'm getting these bills from providers that were somehow involved in my care that I didn't even know about, maybe, that I'm getting a bill from, because it was all part of the process, all part of the care that was provided to me in that emergency setting. And so that was the premise, really the intent behind this whole thing, was to bring that to the forefront and say, you know what, we don't want patients being surprised anymore. And so part one that I refer to, which we'll get into in just a second, essentially applies to those providers practicing in a healthcare facility. Okay, now the rules also went beyond emergency care, though. They went beyond emergency care and they began to speak to non-emergency care by non-participating providers in healthcare facilities. And so all of that's included in part one, is both emergency and non-emergency care. Now, it's, as with anything else, and as a former legislator, I'll tell you, it's all in the wording and it's all in the intent behind why something is brought forward. You have to look to the terminology. And so as you read through this, what this refers to is exactly what you see on the screen: providers practicing in a healthcare facility. So what are the first questions you need to ask yourself? Well, what's defined as a provider? What's defined as a healthcare facility? In this particular case, in part one, we look right to what are their definitions of a healthcare facility. And you'll see right from the get-go, what they're talking about with healthcare facilities is not chiropractic practices in part one. So hold your breath. We're going to get to part two in a minute. Healthcare facility is defined as a hospital, hospital outpatient department, critical access hospital, and an ASC, or ambulatory surgery center. That's in part one. Now then, in part two, if you read through that, all of a sudden you begin to see that they've expanded part two healthcare facilities to include rural health centers, federally qualified health centers, labs, and imaging centers. And when we get into part two, the distinction here is that it applies to providers or healthcare facilities. Part one applies to providers who treat inside of a healthcare facility. All right. And so if you are a chiropractic physician and you're practicing in a hospital setting or any of those healthcare facility settings, then part one will apply to you. And our discussion today is going to be focused on the other 95% of us that don't practice in those types of facilities. But if you are a clinician that does practice in a healthcare facility as defined, then you need to become much more familiar with the rules that are associated with that. And that's another lecture at another time. And what we want to do here is speak primarily, though, to the part two of the law, which speaks to providers or facilities. And of course, that falls right squarely on all providers, whether you practice in a defined healthcare facility or not. And what they did with this rule is they extended the no surprise billing, the balance billing notifications to uninsured and self-pay patients. Okay. And an uninsured patient, we know, doesn't have insurance, or they say they don't have insurance. A self-pay patient is a patient who may have insurance, but those services that you're providing may not be covered or non-payable for whatever reason, or they're electing to not file a claim for their insurance. And so that's who we're talking about here. And of course, right off the get-go, the key definitions here in part two Now we're talking about part two, what does squarely apply to us as providers. They define a convening healthcare provider and a convening healthcare facility, and it's the provider or facility. All right. So it's not one inside the other. It's or, either or. And so it clearly lands right on us and squarely tells us that providers who treat uninsured and self-pay patients need to provide a good faith estimate in advance of those scheduled services or upon request. And as we mentioned, who is defined as that uninsured or self-pay individual? Well, this will give us some clear distinction thinking about these two pieces. Number one, that individual does not have benefits for an item or service under a group health plan, group or individual health insurance coverage, or federal health care program. And of course, Medicare is defined within that, or a health benefits plan. So they may not have benefits. They could have that insurance, but they may not have the benefits for your care, the coverage for your care. So that could define them then as self-pay or uninsured, or has benefits for such services under a group health plan or group or individual health insurance coverage offered by a health insurance issuer, or health benefits, but has chosen to not seek a claim. They've chosen, they've got coverage, they've got the insurance, but you know what, maybe their deductible is $10,000 or whatever the case may be, is why they don't want to file a claim. They've decided, nope, I'm not going to file a claim, and I want to go ahead and pay out of pocket. And so these are the two types of scenarios that defines that individual that is walking in our office, and what we need to make sure that we understand that we are under then the No Surprises Act of providing a good faith estimate. And as we mentioned, since Medicare is a federal healthcare program, a good faith estimate will need to be provided to Medicare patients for exams, modalities, therapies, all of those non-covered services, or if the patient elects to not submit a claim to Medicare for non-payable covered services. So it's that option 2 in the ABN form. And so this is very key and very important for us to understand that the way that the law is written today, this is how it would be applied. And to that group of people in those scenarios. So what is a good faith estimate, Scott? Well, good faith estimate is exactly that notification of the expected charges that you expect to be in total for the care for that patient. And it's that they talk about items and services, and it even goes on to talk about that we provide those good faith estimates not only for the care that we're providing that patient, but let's say a part of your treatment plan is making a referral to maybe a massage therapist, whether that person's in your office or not in your office, or an acupuncturist, or maybe you're going to be referring them out as a part of their care plan to another provider. Well, this law actually goes to the point of saying that co-providers, and that's what they would be viewed as, that those amounts are required to be included in the good faith estimate statement to the patient. Now, you're probably asking like, well, how the heck am I supposed to know what those providers charge? Well, that is a part of the law that says that we have to become familiar with about what that would cost. Now, do I think that there's going to be changes to this law as there gets to be more and more pushback? The answer is I hope so. But the way that the law is written today, this is what's required. Those good faith estimates, again, for the uninsured self-pay individuals, has to be provided in writing and orally, and we'll speak to that in just a minute. We need to make sure that we have written notice. So notice needs to be in 2 prominent locations in the clinic. All right. Needs to be like where they come in, maybe check in, pay, that type of thing. That's a good spot to put it, as well as somewhere visible where everybody can see, as well as on your website, your clinic or practice's website. If you have a website, then it needs to be on there as well. And that you're orally informing that uninsured or self-pay individual of the availability of a good faith estimate. And especially when questions come up cost of items or services occur, and it needs to be in a format that they can understand, a language that obviously that they can understand. And as I mentioned, not only the care that you provide, from your treatment plan and the services that you're going to provide to the patient, that other services provided by outside entities, if they are a part of what you're recommending and are billing into the treatment plan as a care plan approach, that they would need to be required as well. Now, one thing that they speak to is that you can provide a single good faith estimate for any reoccurring primary items or services. So for instance, we're going to get through it, we're going to walk through some scenarios to kind of pull this together in our thinking process, but they make a clear distinction in the law to say that, look, if you're going to have that patient coming back for reoccurring treatments, that you can basically say that, Scott, your treatment is going to be 20 visits and we're going to be doing these 3 things on every visit, and your total cost for that 20 treatments is going to be X amount of money. And one good faith estimate is fine for that reoccurring primary items. And then also note that that it cannot exceed 12 months. And so this is a 12-month deal that we're providing this good faith estimate within that 12 months. And as we mentioned earlier, it needs to be in written form. So it's a consent. So that would be put on a form per the regulations that are prescribed in the Federal Register in terms of what needs to be on that form and the disclaimers that need to be on that form for the patient to see. And then they sign that consent, which would have that good faith estimate provided. So when do we provide that good faith estimate? Well, the law does speak to this. And what I'd like to do is just break it down a little bit for you in terms of scenarios. We have the new patients call in, or we have the established patients call in and they have a new episode of care. Okay. Then we have patients that call in and are scheduled for regular maintenance therapy or wellness care. And then we have patients that call in on an as needed basis. Right. And there may be other scenarios that you can think of outside of these boundaries, but it kind of boils down to these main access points, if you will, for patients. Now, when we provide the good faith estimate in these scenarios, we have to look to that legislative intent. And just like what I mentioned earlier, looking to see as to, okay, why are they writing these rules? And even if there's gray areas, what was their intent? And so this is very clearly defined by HHS in terms of the intent. And you'll see that they want these good faith estimates of the expected charges available to uninsured self-pay individuals upon scheduling an item or service or upon request. And so this means that when Scott calls in as a new patient or an established patient with a new condition, a new injury, I need to be provided orally that, okay, Scott, just so you know, your first visit here, there will be an exam charge. There could be an x-ray charge depending on what is required, and possibly treatment. And so it may range between X and 2X. Okay. And then when Scott comes into the clinic for his appointment, there will be a good faith estimate written to that effect, that the range is going to be from X to 2X. And then I would sign that, and that would be my written good faith estimate for that initial visit. Right. And so then I go in and I see the doctor, and I see Dr. Jones, and she tells me that, okay, Scott, here's what's wrong with you. We took some x-rays, does a report of findings, develops a treatment plan, and says, Scott, I'm going to need to see you, probably 25 times over the next 8 weeks. And we're going to be doing these different therapies and adjusting you, so on and so forth. And so the total amount here is going to be X. And then that is put on a good faith estimate that Scott consents to and signs. That's what we're talking about here. That walks you through that good faith estimate. That also follows me through that full treatment plan then for me, the patient, until we get to the end. And of course, we talked about it not exceeding that 12 weeks or 12 months, excuse me, which it wouldn't. So let's just say that Scott now is an established patient under PRN. Yeah, we spoke to new patient or established patient as a new episode. That was the first scenario. Probably should have been more descriptive there. Second scenario, though, let's say it's PRN. I elect to come in when I feel I need to come in, and so I make the appointment. And of course, the person on the other end is going to make the appointment, and you can orally say that, well, it looks like you typically come in and you understand that you typically pay X amount. And Scott says, yep. Scott comes in, and then you have a good faith estimate in front of Scott then that says, well, here are the services that you typically utilize when you're in the clinic. Here's what they cost. Okay. And then on that form, you want to have a separate form for those patients that basically say that they are electing their care when they need it. And so that good faith estimate then pertains to that dollar amount, and that they elect the care when they need it. Now, if Scott has a new episode, we already know what the process is for that. Okay. And so that would help establish good faith estimate for those patients that are seen on an as needed basis. And then when we think about the patients who are seeing either maintenance therapy or wellness visits that are scheduled recommended visits, they can fall right along the same lines as that treatment plan, because we know that Scott needs to be in once a month or every 2 months or whatever it is. And we can say that you're typically adjusted 3 to 4 regions, and you're going to be seen 12 times in the next year. There's your good faith estimate for that. Scott understands it. He signs it, has that consent, and then you move forward. And so the key thing here, when we talk through this, as you can now think back on what we've talked about, is that there's a notice, that there's a good faith estimate that they have a right to as an uninsured or self-pay patient. And that good faith estimate then is provided to them, and they have to sign off on it and consent and say, yep, I do accept that. Now, it's important to know that those good faith estimates are not considered agreements to a contract. Okay. It's basically just that they understand what it is. That's what they're consenting to. Now, to make the waters more muddy, you're going to hear about different time frames. And we talked about the legislative intent right away, because I think that that's so important to understand. But when they write laws and rules, they don't always keep in mind us, from the chiropractic practice perspective, okay, or outpatient perspective. And so what they did was they developed certain timelines that are not typically common in our practice. They could be, but they're not typically common. So what do I mean by that? Well, the first one, they speak to that when an item or service is scheduled at least 3 days before the date, that you have to provide the good faith estimate no later than 1 business day after they scheduled. So if you had a patient that's scheduled 3 days in advance, that means that you'd have to provide that good faith estimate no later than 1 business day. Well, what did we just talk about as being a good practice? Right away, give them an oral estimate, good faith estimate. And then when they come in, they can do the written. All right. And you can see we can stay ahead of these timeframes without getting into trouble. The next one has to do with scheduling at least 10 business days before, and that you have no later than 3 business days after scheduling. And then, of course, the third one refers to that if somebody walks in the door and says, I want a good faith estimate, that we have no later than 3 business days after that date of request. And so these are some standards, if you will, that were criteria that was put into the law. But again, I want to bring you back to the legislative intent and what HHS put in the Federal Register, and that is upon scheduling and upon request, or upon request. Okay. And so we right up front, being right up front with all that is going to be very important to be able to avoid having any issues or being blamed for not providing notice or getting that good faith estimate done in a timely manner for the patient. Because the whole idea behind this, again, has to do with that patient, Scott, being able to understand what the cost is going to be, and then he needs to decide, okay, am I going to do this or not do this? Or do I need to go look at another approach to my care or whatever. And that's the point of opportunity that this legislation is working to make happen, if you will, is to give that patient full transparency of what that cost is going to be so they can decide what they want to do. All right. So having said all that, of course, there's a dispute resolution process. So what happens if there's problems, or what happens if a patient gets ticked off? Let's say that Dr. Jones, she told me that my care was going to cost $1,000. And I'm like, okay, that sounds good to me. Well, at the end of the day, it cost $1,500. And that torques me. Okay. I ended up paying $1,500. You said it was going to be $1,000. That could spark a dispute resolution. And so the law has set up dispute resolution entities that will help patients and providers work through this. But there are two key requirements before a patient can bring that claim into dispute. Okay, so the very first one is that it has to be $400 or more above the good faith estimate provided to them at the beginning of care. And secondly, it has to be initiated within 120 days. So if both of those requirements have to be met for that patient to be able to have standing to drag you through a dispute resolution process about their bill. All right, so $400 and 120 days. Now, how can we avoid that from even getting to that $400 or $1,500 or extra over that? Well, how you avoid that is that, as we know, when we're treating patients, we can start out with the greatest of intentions. We've got a treatment plan that we're projecting. It's going to take 20 visits over 6 weeks, Scott. Great, here we go. Well, Scott slips on the ice in South Dakota and falls in his butt in his garage. Okay, well, that just extended the care, didn't it? It exacerbated it. It's going to take another 2 weeks to heal. It's probably going to take another 8 visits or whatever the number is. That could put me over 400. Okay, so you at any point in time, the law does provide for you, the clinician provider, at any point in time to make adjustments to that good faith estimate. And so we recommend that you be mindful of that through aggravations or exacerbations, that you're updating that good faith estimate so that you don't run into this issue with having to defend yourself, if you will, through a dispute resolution process. So here we go. At the end of the day, what do you need to do? And what does this law speak to? Well, give notice. So again, 2 prominent locations. If you got a website, got to have that. Patients call in, you're giving them notice. You orally provide them a good faith estimate. You have a written good faith estimate that you put together. You're obtaining their consent, just like we talked about. And then from that point, understand that dispute resolution process, just like we walked through. And how do you prevent that? How can you get ahead of the curve on that ever happening in your practice, and setting up the proper protocols and procedures? Regarding the noticing requirements, drafting the good specific good faith notice, of those expectations, displaying that notice again on your clinic website. 2 prominent locations. I guess we spoke to that here already. There are a bunch of links at the end of this PowerPoint that we provided for you that you can go check out, and you can put these forms together and your public notice together. They do give some model forms for you to be able to do that. And again, if you have a website, it doesn't say you have to go build a website, but it says if you have a website, then a 1-page notice. And of course, making sure that you do contain or have available all those key points that are noted. And here's a link that again, that you can go ahead and take a look at those model notices and what those collection requirements are. We recommend that you update your policy manual. I can't emphasize that enough. Your compliance manual that you have, make sure that you outline the procedure to comply to this law. And then also you want to reference that dispute resolution process. Now, you should already in your compliance manual have a grievance procedure. that patients come in. So whether it's for HIPAA purposes or for other types of compliance purposes, complaint purposes, patient complaints, that you have that, well, this should dovetail right into that piece. And then if you are in a group practice and you have provider agreements, okay, I'm recommending to you that you'll want to look hard at those provider agreements and make sure that you have coverage, you as the owner doctor in those situations, coverage in there that your providers know that this is expected of them to be able to provide these good faith estimates. They are the ones that are in control of designing the treatment plan. And so when they design that treatment plan, then they need to get good at providing that financial report of findings, which basically every practice should be doing, to get to the point where you can complete that good faith estimate. And then, as I mentioned, you'll be getting this PDF version here. Happy to share that with you. Compliments of ChiroHealthUSA and ChiroArmor. But these are the links that you can go and learn more about it. And then just a couple more things here, Christy, just before I close my mouth. The future rulemaking. This was kind of interesting as you read through part 1 and part 2. What's interesting about it is that, and I don't see that as a former legislator, again, I never saw this in our state anyway, but in many areas within the rule that was passed and published in the Federal Register, HHS would say basically, well, here's the requirements. Oh, and by the way, why don't you tell us what you think too? We'd like to know what you think about that. And it just really struck me as odd, that even we're kind of like, it's almost like the cart got put before the horse a little bit. And I've noticed that with other pieces of lawmaking too over the last year or two. It's kind of like they give us some gray and then they're going to kind of figure it out as we go. And I don't mean that as a criticism to policymakers, but that's what I call it the way I see it. And so we can expect more future rulemaking. I mean, this is going to be a bit of a moving target. And so I guess, keep that in mind. This is not hard and fast. It is today, the way the rule's written today. Everything I told you is hard and fast. That is the way that it is. But moving forward, that could change. And I just want you aware of that. And then this was I was on a CMS call here just a few weeks ago about this particular rule. And they gave us this email address. And of course, you can about imagine I had 4 questions I wanted answered by them. And so I emailed them and I have yet to hear from them. And there were, I don't know how many thousands of clinics and providers and consultants or whatever on that call with CMS. So I just know that they were unable to answer a lot of questions that were asked several weeks ago. And I have not gotten a response from mine yet. So again, I just want you to know this is the way the law is today. This is the best way to comply with it today. And just be aware that we'll need to come forward with some future updates, Christy, as time goes on. So, with that, Christy, do we have any questions?
Oh, do we ever? So, would this apply to clinics who are cash only since all of their patients would be self-pay?
Yes, clearly, no question. This is all about uninsured self-pay patients. Period.
Okay. How do we handle Medicaid claims for services in excess of what is allowed? For example, how do we bill for visits number 16 when only 15 visits are covered? Do we need to bill at the Medicaid rate, or do they sign an ABN to not bill Medicaid and bill at our usual rate?
Okay, I heard Medicare and then I heard Medicaid.
Yeah, I did. It's all about Medicaid. So, but they talk about the ABN, but that's not used for Medicaid. That's used for Medicare.
Right. So Medicaid, and I'll just speak real briefly to this then. From the Medicaid perspective, that will all be contingent upon your state and your state Medicaid guidelines. So if it was more of a Medicaid question, then I would really default to contacting like your Medicaid Department of Social Services, whatever agency is overseeing that or administrating that program. That's where I would go. In regards to if it was strictly Medicare, Can you restate the question now so I can think about it in that context?
How about we come back to that one?
All right, very good.
Okay. Can you provide a sample of a good faith estimate form that we can tailor to our office?
Well, there's examples on HHS. They're a bit clunky. If you would like more information about what we have to offer in kind of like a full training program, staff, doctor, and then forms that we've developed, you can go ahead and reach out to us at info@chiroarmor.com. But otherwise, all the links that I provided you are information that you can learn in terms of reading the Federal Register and knowing what those requirements are for a good faith estimate, and for uninsured and self-insured. The model notices, they have some information about that, and then you can use those as your resources, unless you would like to find out what we have for you.
Will I need to create a written good faith estimate for all of my existing patients, or is this just new patients moving forward?
It's everybody that walks in your door today that is uninsured or self-pay patients.
Can we create a grid matrix with all of the charges in our office that are possible and just have it posted?
No. Nope, it needs to be specific to the patient. So if we told Scott that he's going to be getting, or we're projecting in our treatment plan, he's going to get 20 visits, and it's going to be adjusting and e-stim, and the cost is going to be X times 20. That's our good faith estimate. And so we can't just say, here's our fee schedule, it's going to be based on this. No, it's not enough. That does not comply to the letter of the law.
Is the signature on a good faith estimate absolutely required? Can we send it electronic to the patient? Why do they have to sign it?
So the signature requirement is something that was silent in the rules. However, again, I'll go back to the intent. If you want to demonstrate that the patient got it, you will want them to sign it, so that if anybody came back to you and said, how do I know that the patient got a good faith estimate? I mean, how do you defend yourself in that situation? The only way you can defend yourself in that situation is if you have the patient sign it. And so if you, in fact, just handed it out and gave it to the patient, and maybe you retained a copy or didn't, again, then you're left out in the open. The patient could say, well, I never got it. And then what do you have? Kind of recourse do you have? So that's why we recommend it's treated as a consent, and the legislation speaks to it as a consent, but it doesn't specifically say the patient has to sign it. But we want you protected, and it only makes sense to us that you would have them sign it. Now, can you provide it to them electronically? Well, you can provide it to them any way that the patient wants it provided to them by. It could be electronic, it could be in written form, but the law speaks directly to written and oral. All right. And that if the patient wants it a certain way, you can provide it to them. But again, I just want to be clear. I'm thinking about you and about what if, and I would not want your back not covered by not having it signed by the patient.
Okay, so I understand a good faith estimate is required for self-pay. Is it required for patients that file insurance as well, like if they're out of network?
So the answer to that would be no. So if they're filing a claim, and let's say you do the services and you provide that claim or information to the patient, whether you file it for them or they file it, what it would cover though is if that insurance company didn't cover the benefits. So let's say, for instance, they didn't cover certain parts within what your services that you're providing, then that falls into a self-pay situation. And if you remember, go back to the scenario or to the definition, and I'll buzz back here. Yeah, right here. does not have benefits for an item or service under a group health plan. So, I mean, if that would apply, whether you're par or non-par.
Let's see. What if a patient doesn't make you aware that they are going to be self-pay until the day of service? Do you still need to provide a formal estimate?
Yes. Yep. Then you would do it upon right at that point that you know. Mm-hmm.
Okay. Let's see. There are so many questions in here. Are Medicare, Medicaid, and federal health plans exempt from this?
No. And so you can see that the federal healthcare program is included in that definition. And I'm sorry, Christy. I'll just move right to the next slide too, because specifically, and this was the example we brought out, with Medicare, that it would be provided to Medicare patients, because we know that Medicare doesn't pay for our exams or modalities, those non-covered services. So it would need to be provided for that. Or if within the ABN where we know it's not going to be payable, covered services that are going to be non-payable because they're maintenance therapy, and the patient checks option 2 in the ABN form saying they don't want their claim filed with Medicare, then they would fall under this uninsured self-pay situation. I'm sorry, go ahead now.
Do you think it would be a good idea for the provider to check with their liability insurance carrier to see if they will need additional coverage for errors and omissions?
Well, I think this would be a great commercial for the Choose a Defense insurance, which essentially is that, from a compliance perspective. And so I would recommend that you do check with your liability carrier and see what they do have available. I mean, 20, 30 years ago, I wouldn't even have thought we'd even be talking about that. And those of you that have been around as long as I have or longer know what I'm talking about. But with the amount of information that's out there, and the more that you think about outsourcing help in certain areas and making sure that you've got some risk covered, like through types of insurance or that type of thing, that's just the way that business is today. So I think that's a great question. And my answer to that is, absolutely seek coverage to make sure that you can have, a bit of a safety net, if you will.
Our clinic provides a detailed estimate after the care plan is set in place once the patient has been examined. As the case manager, I provide details about the general cost of the exam before coverage after a free consultation with the patient. Will we have to change that process in light of the details discussed today?
No. So that's great. And the only thing that you'd have to do is just make sure that you follow what is required in a good faith estimate, and those requirements and the disclaimers that need to be on that form that they would sign, that consent form that we talked about that they would sign, and just make sure that's included in your paperwork, or if you have a separate form, whatever. But you're following that to the letter of the law. Just make sure that you've got that completed and wrapped up, and have that, signed by the patient. And there's always a good and bad, with this. Nobody likes to have to do things, right? But the good thing is that, it does give us the impetus to have this financial report of findings that we should have with our patients. I mean, we shouldn't hide behind that, in my opinion. I mean, we need to get it out there because we have a great value with the care we provide. It's a great value. And they need to know that, and we can use lots of ways to be able to compare that value to what else is out there if they don't know it already. And so at the end of the day, practices that we work with, and I know other practices and people that work with practices will say as well, that those practices that do have this part nailed down, like this individual that just said that, I know they must, because of how they do their process. It's less stress, and patients know what to expect. You don't have arguments. It's like right up front, there's clarity and it's taken care of and we know how we're proceeding and we can focus on care. And if there's adjustments that need to be made, like we talked about, just keep in mind, the second part of that answer to that question would be to watch that then and make sure you don't exceed that substantially in excess of $400. If there's something that occurs during the care process of the patient or something changes or whatever. But yeah, the point being is that the more that we can systematize this part of our practice and our reported findings, I think is going to be a good thing at the end of the day.
Do we have to provide a good faith estimate to patients who are using ChiroHealthUSA?
Yes. And so that's a part, again, that ChiroHealthUSA has got a ton of this covered. And I'm working with Christy on that as we speak, that there's just a couple T's to cross and I's to dot to make sure that those forms and the way that things are, and just an update on the financial policy is complete. But absolutely, when you look at it from that perspective, having a system in place like that for these types of patients can make it very turnkey for you in your practice.
A good faith estimate is required for all self-pay charges. What about PI, workers' comp, auto, especially when claims are denied?
So,
I have another one that's close to that too. It says, well, obviously verification of benefits is super important, but what if the benefits quote is wrong? So I'm assuming that this is you're covering, a lot of people are asking this in different forms.
Sure. Right. My answer to that would be to make sure that you have it covered. What does that mean? Well, I would probably, if you're suspecting that there could be issues, then it probably would be a good, and that there would end up being a self-pay situation. It might be good to, as soon as you're aware of that or have an inkling to that, to go ahead and put a good faith estimate together and be able to have the patient sign that so that they understand it. And I know with personal injury, you've got liens and other types of agreements that you can have, with the patient, and which would already speak to some of that. But again, this was primarily, and this ends up being kind of a bit of a gray area too, like what I was referring to, that we'll probably see more clarity as months go down the road in this area, because this whole piece was defined towards those people who would be considered uninsured or in a self-pay situation. But and to follow the letter of the law, or that intent, legislative intent, as soon as you are knowledgeable of that, then that is when I would recommend that you seek that good faith estimate and notify that patient, no matter what the situation is there.
Do out-of-network providers have to do a good faith estimate if the care is covered under a patient's plan, but the patient has a very high deductible?
And if the patient is electing to file a claim, the answer is no, because again, it all boils down to if they have benefits that cover that item or service. That is a really key piece of that. And that's why I kept this slide up, that you could see that. So if they're planning on filing a claim, and if they have benefits for all the items or services, then you're good, because they're not, even though they're paying for their deductible, they're filing their claim.
Okay. Does the notice regarding no balance billing and good faith estimates need to be posted in every clinic location in each checkout, or just one sign per location?
They actually state two prominent areas within the clinic. So if you have multiple clinic locations, two prominent locations inside each clinic location. And they even specifically say a good place to put it would be where people check in or pay. And then, another area where that they're going to see it. Maybe they walk through the front door, it's in the entryway, or maybe a prominent area within the waiting room would be another good place to put it. But you decide that. And then the second part of that, piece of that, has to do, if you do have a website, to make sure that you do have a web page that speaks to that as well.
Okay. What's the rule for balance billing as an out-of-network provider? Are we allowed to collect only in-network patient portion?
Read that to me again, Christy.
What's the rule for balance billing as an out-of-network provider? Are we allowed to collect only the in-network patient portion?
So I'm assuming that this provider is not inside of a healthcare facility. So remember, I'm going to drag you back here. Remember, part one had or spoke to non-PAR providers in a healthcare facility that is PAR. Then those, to answer that question in that particular scenario, is that if you didn't get notice and consent from the patient, then the answer is yes. You would have to accept what that insurance company would provide you under the and there's actually three areas, and I don't have it in my slides here today because I knew most of our conversation was going to be on part two, but it could be by state rules or state law, or it could be through what they call a QPA, which is a qualified payment, and I can't remember what the A stands for off the top of my head, but it's basically a formula that insurance companies can come up with that would tell them what's reasonable and customary. So in that situation, then yes, you would have to accept it if you didn't give notice or get consent from the patient to balance bill them if you practiced in a healthcare facility as a non-PAR. Okay. If you're thinking of it just as, well, no, I'm practicing by myself, Scott, that scenario, then again, we revert right back to what we've been talking about. Do they have benefits for an item or services? Are they filing a claim? If they're filing a claim and you're non-PAR and they have benefits for the item or service that you're applying to, then they are not considered uninsured or self-pay in this definition.
Okay. Would you need a good faith estimate for self-pay services like weight loss programs?
It doesn't matter what you're providing. So it says item or service. And so the answer would be yes, you would need to.
Okay. Am I understanding that this applies to healthcare providers that are in private practice, not just emergency, ambulance, and hospitals?
Correct.
Okay. Let's see. We're going to answer a few more. Okay. So this applies to all patients starting January 1st, new and existing patients, correct?
Correct.
Okay. Just in case y'all think I'm not reading your questions, I'm just rewording them to clarify them a little bit. And I'm combining some of them. Do we need to disclose anything prior to the report of findings in regards to fees ahead of time?
So if they're calling in, that's when you can provide them the oral good faith estimate. So for instance, I think the scenario that I gave was probably pretty clear along those lines. If I'm a new patient, then you're going to say, well, Scott, between the initial exam, possibly x-rays or treatment, the range of cost could be between X and 2X. Okay. And then when Scott comes in, then there's a good faith estimate that I can sign to that effect. And then when I go back and the doctor sees me, does a treatment plan, that's when you're going to go ahead and put together another good faith estimate for that treatment plan. That could be 12 visits, these services, total amount is going to cost X. And then Scott signs off on that.
Is there a modifier for them to indicate that a GFE is on record for the claim form?
No, don't give them any ideas.
I was just going to say, I didn't hear that one mentioned, but I can see that coming soon.
Yeah.
Let's see. Care by other providers is not required on the GFE form until 2023, correct?
No, that is not what I understand. Nope. And I'll go back and read I can't tell you how many times I read that, but that is not how I've interpreted it. But I will go back and check, because I was wrong once last year. And this could be my once this year. You never know. But from what I understand and what I've read, that co-provider, those services need to be identified, need to be within the good faith estimate.
Okay, I think we got to almost all the questions, and I was trying to get through the ones that are not duplicates. So if for some reason, your question did not get asked and you would like to submit that question to get an answer, or if you're like me and you think of all the questions after it's over, like right after it's over, I'm putting in, it's info@chiroarmor.com, and that goes to Dr. Scott and his team. Oh, I don't know what I did. I just accidentally had a box pop up with code on it. Whew. On my computer. That was scary. Because I don't know what any of that means. But anyway, so it's info@chiroarmor.com. Dr. Scott and his team will get you the answers to those questions. I want to thank you so much for coming to our very special webinar today with our very special guest, Dr. Scott Munsterman, and all of you very special people. I'm so excited. I love seeing all of y'all. Hey, Lisa. And Christina and Michael. I'm so excited. I love these are all my people. I see them all the time on the webinar, and I get so excited. And Julie and Rachel doesn't come all the time, but I do like it when she does come by and say, hey. So if you think of anything else, and Valerie, I'm sorry, I didn't miss you. But if you think of any other questions, please send the email at info@chiroarmor.com, or if you forget that part, just email me, Christy@ChiroHealthUSA.com. I will send it over to the Chiro Armor team to get that question answered. And Dr. Munsterman, if you could send me your PowerPoint slides so I can make handouts and send them to everybody, because some people were falling behind trying to take notes. I told them to stop taking notes and just listen, and I'd send them the recording and the notes afterwards.
Yep. That's perfect. That's perfect.
All right, everybody. Have a fantastic Thursday. I hope you have a very stress-free, relaxing, and beautiful Friday and a fantastic weekend. We'll see y'all next week. Bye, y'all.